note about that. Okay, this part about suicide, I wanted to mention that suicide, one of the mnemotechnics is sad person because it includes the sex for male, more frequent risk for suicide, patients aging over 60. Remember, suicide, even in the United States, 60 and older commit more suicide currently than any other age in the United States. Depression, patients with depressions, a previous attempt, the use of ethanol, or alcohol and drug abuse. This one, rational thinking lost. Suicide and family organized plan and access, no having a support, and being sick. That's why usually elderly commit suicide. The thing is that some of the data, let me go here. Some of the data in the United States have been changing during the pandemic. They were different numbers, even though we don't have, this was just a survey. It has not been published or maybe more data taken, but teen girls who experienced sex and violence during the an increase during the pandemic 2020-21 was 20% higher increase in suicide attempts or ideation. And this is very serious numbers. Sorry about that. They're doing the garden right now. Okay. With respect of suicide data, older adults are the among high suicide rates throughout every region of the world. Suicide is more committed in the developing country. In those developing country, usually is related with people that's living in poverty. It's also related with young women that are striving to survive. It's also, and they don't have a good education. What else about suicide? So suicide ideation is just thinking. Suicide behavior is about the action, okay? It's different. Suicide ideation is one thing. Suicide behavior is already the behavior, the action of doing the act, okay? And suicide attempt is the one that already did the action. And after a suicide attempt, you can be successful or not successful. If it's successful, the person died. If it's not successful, it didn't die, okay? So when we talk about risk factors, it increases after every suicide attempt, okay? That suicidal attempt is a suicidal behavior. Okay, we have two things here. When we talk about the etiology, we have internal psychopathology and external psychopathology. The internal psychopathology has to do with what's coming inside of that patient. Anxiety disorder, mood disorder, hopelessness, emotion, disturbance, sleep disturbance, that's from inside. From outside is anything that surrounds that person, like aggressive behaviors from other person, okay? Antisocial behaviors, substance abuse, it comes from outside, okay? Apart from that, we have demographic factors. I told you about education, unemployment. We have social factors like abuse, sexual abuse, family problems, isolation, peer problems. That's very stressful life events. That's a social event, social factor. Very, very important. Sometimes we don't take that into account, but stress is one of the factors as etiology for suicidal. And of course, the one that we talked before is prior suicidal thoughts and behavior, okay? And this is just to indicate, because we tend to forget, we think that urbanization, and this has been published, does not have to do with suicide, but it does is significantly increasing suicide rates by decreasing urbanization. So what this means, let me see, this is a large central metro. It's in color blue and green, right? And micropolitan is this one, and non-core is this one, right? So this is 1999 and this is 2017. So if we see and we compare urban versus rural, or not urban, right? With urbanization, if we increase urbanization, maybe we could decrease suicidal attempts. So significantly increasing suicidal rates by decreasing urbanization, or said by another way, when we don't have urban development, we have higher rates of suicidal attempts. Is this clear? I don't know why these authors complicated this too much, because you can say it in another way. Okay. Okay, I already talked about this. Suicide is the second leading cause of death in the age of 14 to 25 in the United States. And this is, it was the third in 1980, and by 2018 is the second cause of death. I did not find the 2020, 2021 because it was not, still, I could not find it. It's there. I think they're still doing it, but this really shows up in the data. Young people, they're taking their lives. That's not a good news. And suicide by mental disorder, depression, 50% of those that commit suicide have experienced depression. So these data is a little bit different. Okay, so if I have a patient that had experienced depression, if I see 100 of those patients, 50% is going to commit suicide. If I have 100 patients with anxiety, 70% of those are going to commit suicide. And this is the way that we shown up the disorders based on suicide. Schizophrenia, 40%. These numbers vary. They vary a lot, okay? Year by year. So I'm not going to ask about this, because if I ask you, I need to give you the source, okay, of this. I just want you to know which mental disorders are high risk for suicide. So you know about schizophrenia, about bipolar disorders, okay? It could be almost as depression. You know about MDD, major depressive disorder. You know about a lot of anxiety disorders that can put you at risk for suicide. And we also talk about borderline personality disorders. Are they other mental disorders that can commit suicide? Yes. Gender dysphoria, dissociative disorder, dementia, and substance abuse can get you to commit suicide. Okay, any questions? Can I go on? I told you this was very long. Mood disorders. Okay, so we have for mania and for depression, some of the mnemotechnic. I don't know if you heard about this. DICFAST for mania, distractibility, insomnia, grandiosity, fights of idea, activity, agitation, speech, thoughtlessness. And for depression, seek CAPS, sleep, interest, guilt, energy, concentration. So these are like the 9 things that you're going to look in a vignette for depression. These are the ones that you're going to look in a vignette for mania. We talked about also that mood disorders are going, it's a spectrum. It goes from the blue side to the orange side, being the mania and psychosis, the one that only occurs for type 1 bipolar disorder and also in psychoaffective. And the blue side, extreme with depression, suicide, and psychosis, occurs in the major depressive disorders. And you have all the in between. Type 2 bipolar has hypomania. It never has mania. That's the important thing of this chart. Okay, risk factors for MDD. We talked about neuroticism, one of the most temperamental risk factors. Also, adverse childhood experience, including sexual abuse. Remember, MDD is very important for women, and sexual abuse, that risk factor specifically is important in women, stressful events, and other types of social determinants. Genetic, it is a genetic, it runs in family, first degree family members, 40% of inheritance. These are some of the symptoms. I'm going to go a little bit fast. So about the pathophysiology, what I want you to know is that almost, if you see here, serotonin is low, epinephrine and dopa and epi are low. We have two main hypotheses for MDD. One is going to be the high cortisol or hyperactivity of hypothalamic pituitary adrenal, and the other one has to do with low levels of all the MAO or monoamine neurotransmitters. And this is what is this talking about? Bipolar disorders, we're going to have type 1 and type 2. I already talked about that. With respect to rapid cycling, the one that has rapid cycling usually is being type 1 or type 2 is going to be seen in women. So let me go here. I put you here the answers of one of the activities that we did in class. So remember that genetic is important for both. Sex prevalence in bipolar 1 in the US is slightly higher in men than in women. In bipolar 2, it's more common in women than in men, but also that reflects some that the women go and seek for help more than men for bipolar 2. Remember, bipolar 2 is difficult to diagnose. In the case of other gender difference, women are going to experience rapid cycling in mixed states. They're going to have more mood exacerbation on either of the two, bipolar 1 and bipolar 2, and they're also going to experience what we call postpartum psychosis. Okay, that is one of the main difference. So postpartum psychosis, in the case of bipolar 2, they're going to have hypomania. In the case of bipolar 1, they're going to have mania. They are at risk of mania. Remember, mania state or mania episode is an emergency. You need to hospitalize the patient. Let me go back. Do we need to have do differential diagnosis with medical causes for mania? We do, and with medications also. So we have some medical conditions, including HIV, that can produce mania, okay? So that is a medical condition. Also other neurological disorders and metabolic. In the case of medications, anything can produce, special bronchodilators, dopamine, antidepressant, dopamine agonists, antidepressants, corticosteroid can produce mania. So those are some of the medical substance abuse and medication use. Okay. For bipolar disorders, I want you to remember that there is implication of the immune system causing inflammation on the etiology of bipolar disorder. And that's it. That's the only thing I mean, it's part of the pathophysiology that has been described. Okay, let me go here. We also talked about premenstrual dysphoric disorder, and about this one, I don't know if you remember that I mentioned premenstrual dysphoric disorder also as one of the disorders that has a risk factor for suicidal attempts and for suicidal ideation. By the way, premenstrual, as the name it says, it occurs before menstrual period, okay? And it has to do with the luteal phase. Okay, any questions? I don't know where we are, but nope.
No questions.
No questions? Okay. For anxiety disorder, okay, I think that is out of the way. See? Okay. So we have, for anxiety disorders, I mean, we can have a classification depending on the length. So usually less than 1 month, more than 1 month, less than 6 months, more than 6 months. So acute stress, less than 1 month, adjustment disorder, less than 6 months, panic disorder, more than 1 month, PTSD has to be more than 1 month, phobias like agoraphobia, social phobia needs to be happening for more than 6 months, generalized anxiety disorder for more than 6 months. So in the case we didn't talk before about a panic disorder, there is a structural problem for panic disorder that has to do with the amygdala and with the hypothalamus. And we need to make the difference between what is a panic attack and what is a panic disorder. Remember, a panic attack is very acute. A panic disorder has to be happening to this person for a time, let me go here, for at least 1 month, okay? That's a main difference. A panic disorder is a mental health problem and it's chronic. A panic attack, anybody can have a panic attack and not have a panic disorder. We need to differentiate panic disorder from other conditions. Some of the conditions can be medical conditions like an arrhythmia, a temporal lobe epilepsy, an embolus, pulmonary embolism. You can have a panic attack. You're having problems breathing, you're feeling bad, and you can have a panic attack, but not exactly a panic disorder, okay? We have comorbidities for panic disorder. Some of those cannot be associated with panic disorder are PTSD and generalized anxiety disorder, so they can go together. A person that presents an agoraphobia, this is one of the vignettes of a person. She is fearful to go in public. She's fearful to have a panic attack. That's an agoraphobia, not going outside, okay? And some of the pathophysiology or neurophysiology for anxiety disorders that I would like you to remember is like the levels, what we talked about at the beginning, right? So for example, for PTSD, one of the factors, this is a corticotropin releasing factors, the corticotropin or cortisol releasing factor. It's going to interact from the hypothalamus to stimulate the levels in the release of norepinephrine in the cortex. And that is the one, because we already said that in PTSD, we are having high levels of norepinephrine, right? But who gives me the signal? Who gives me the signal so that norepinephrine goes elevated? It has to do with the corticotropin releasing factor or cortisol releasing factor. Also in PTSD, we said at the beginning that we have decreased levels of GABA and increased levels of glutamate. I would like you to remember 2 key words in PTSD: norepinephrine and something that has to do with cortisol. In this case, the releasing factor for cortisol, okay? In generalized anxiety disorder, we are going to also have elevated norepinephrine and also low serotonin. So if you compare in anxiety disorders, generalized anxiety disorders and PTSD, what is the common path on those two? Anyone? No? Okay, and what else?
Well, it'd be norepinephrine.
There's two things common. We have high levels of norepinephrine, okay? And what else?
And cortisol?
And cortisol. And what about serotonin? We're going to have low levels of serotonin, okay? Let's see if that's true. I think let me see if okay. Okay. Thank you, Celinda. Okay. So, let me see if I don't want to go back here. I don't know how to get out. Well, I'm not going to get out because then, but I will go back to this at the beginning before we end. So what I want you is to correlate the information, okay? Oh, this is anxiety disorder. Anxiety disorder has to do what makes me move, what makes me have that arousal, has to do with motor, has to do with what epinephrine, right? In this case, norepinephrine. But my serotonin is the counterpart, is going to be low. Norepinephrine is going to be high. Usually anxiety disorders have like the same high norepinephrine, low serotonin, okay? In the case of PTSD, also cortisol levels, okay? So here, yes.
Sorry, I was just wondering if you could explain, it just doesn't make sense in my head, like why is there low cortisol in PTSD? Since isn't cortisol like stress?
Okay. I don't know. But I do know that those levels of low levels of cortisols are the one that are going to elevate the corticotropin release factors. We don't have high levels of cortisol in PTSD. Maybe because it's a chronic situation. I don't know. I really don't know. But I do know that this factor is the one that's going to release the norepinephrine.
Thank you.
But I really don't know the answers. We can look it up. Okay, in generalized anxiety disorder, also we talked about inflammatory process in the amygdala. And this is one of the this is pathogenesis for GAD was one of the exercise. The others do not apply. Okay. This is PTSD, also amygdala. Remember, the amygdala is the one brain structure regulating our emotions. Prefrontal cortex is the one controlling it. It has been indicated that in PTSD individuals, we have hippocampus reduced. We have problems in the amygdala overreacting, and we have the medial prefrontal cortex appears to be smaller and less responsive in patients with PTSD. So, summarizing PTSD, there are several things. We have elevated levels of CRF. We have elevated levels of norepinephrine, low levels of serotonin. We have also structural changes in the limbic system, specifically amygdala, hippocampus, and prefrontal cortex. Okay. Do I have to make a difference diagnosis for anxiety? I think we talked about this with medical conditions and with substance abuse. I think we already covered this. It's repeated. But, oh, I know why I put this, because this is an exercise and the one that you needed to complete it right in the class. There are some patients with some medical conditions that can feel anxiety. Intoxication of cannabis produces anxiety. Caffeine intoxication produces anxiety. Also alcohol. Excess